Thank you to the committee for selecting our abstract titled Malignant Features in Pre-Treatment Metastatic Lateral Lymph Nodes in Low Rectal Cancer Predicts Distant Metastases and Survival, but not local recurrences. We have no conflict of interest. I was funded by the Florey Fellowship from the Royal Adelaide Hospital. Low rectal cancer metastases normally spread in two ways. Through this blue area over here, along the IMA, inferior mesenteric artery, along the mesorectum, or further away from the rectum to these lateral lymph nodes here indicated in yellow. Up to 20% of the low rectal cancer patients harbor abnormal lateral lymph nodes, and they comprise a diagnostic but also a treatment challenge. Here indicated in red, a lateral lymph node that is enlarged. Enlarged lateral lymph nodes predict local recurrences when they are treated by the Western standard of neoadjuvant chemoradiotherapy followed by TME. However, not much is known about the impact on oncological outcomes when malignant features are present in these lateral lymph nodes. We conducted a multicenter cohort study in 5 tertiary referral centers in the Netherlands and Australia, and we included patients diagnosed with a low rectal cancer with or without abnormal lateral lymph nodes on pre-treatment MRI. All patients underwent neoadjuvant chemoradiotherapy followed by TME. Lateral lymph nodes were considered enlarged with a short axis of 5 mm or larger on a pre-treatment MRI, and malignant features were defined as internal heterogeneity and or border irregularity on the pre-treatment MRI. Here indicated with the white arrow, a enlarged lateral lymph node without malignant features, and here with a red arrow is indicated a lateral lymph node with malignant features. 213 patients were included. 2/3 of the patients were male, and the median age was 64 years. 98 patients had normal lateral lymph nodes, and 115 had enlarged lateral lymph nodes of larger than 5 mm with or without malignant features in these lateral lymph nodes. Median pre-treatment short axis of the lateral lymph nodes was 7 mm, and 60 patients had lateral lymph nodes harboring malignant features. Local recurrences, according to size of the lateral lymph nodes, was significantly better for patients with smaller lateral lymph nodes. And when we looked at the distant metastatic free survival and overall survival, there was no differences between patients with smaller lateral lymph nodes or larger lateral lymph nodes. Interestingly enough, when we looked at the malignant features and the local recurrence-free survival, patients with malignant features had similar local recurrence-free survival as patients without malignant features, as shown by this survival graph. However, patients with malignant features had significantly worse distant metastatic free survival and worse overall survival compared to patients without malignant features. Of course, this is a retrospective multicenter cohort analysis, so we had a variety of patients and treatment modalities, also with the neoadjuvant chemoradiotherapy and the adjuvant chemotherapy administered to patients. Also, restaging was not standard performed to our patients. And of course, we have no response captured of the lateral lymph nodes because no lateral lymph node dissection was performed, so we don't know if the neoadjuvant chemoradiotherapy was effective. The future studies by Y et al. And the Lateral study, both currently recruiting, will tell us the answers to these questions. Nonetheless, unlike size criteria, malignant features present in the lateral lymph nodes on pre-treatment MRI may predict worse distant metastatic free survival and overall survival, but not local recurrences. Thank you for your attention and good day from Adelaide, Australia.